I'll be talking about Descemet membrane detachment, and this is something which is not a very uncommon condition. You get to see small Descemet detachment in many of the cataract surgeries or intraocular procedures, but most of them are innocuous. They resolve spontaneously. However, there are some extensive DMDs which require desmetopexy, which require intervention. And as I said, the most common causes are use of blunt instruments entering into the eye that can result in Descemet membrane detachment, sometimes due to excessive manipulation, sometimes even doing a wound hydration can cause Descemet membrane detachment. And if somebody does develop Descemet membrane detachment, there is persistent corneal edema, there is blurred vision, there can be corneal haze, which is visible directly. And when you examine the patient on slit lamp, you get to see a membrane, as you can see here, a line, a membrane behind the section of the cornea, and that is the sign of a Descemet membrane detachment. And if the cornea is quite hazy and you are not able to make it out, then ASOCT helps you not only to diagnose DMD, but also to give you the extent and location of DMD. And it helps in management of DMD in doing desmetopexy. So as far as the DMD is concerned, it can be located in various parts. It can be peripheral, it can be central. The height can be variable. It can be less than 1 millimeter, which is called planar. It can be more than 1 millimeter, which is called non-planar. Sometimes the edges can be scrolled. So all sorts of things can happen. As you can see here, an example of a peripheral planar DMD, a central planar DMD, again a large central planar DMD, then again large central non-planar DMD. And so based on the configuration, based on the morphology, we evaluated cases of DMDs. It was a multicentric study which we did along with Professor Harminder Dua, who gave the concept of Dua's layer. And by studying all those cases, we gave a classification of DMD in which type 1 is detachment of both Descemet membrane and Dua's layer, but they are both attached to each other. In type 2, there's detachment of Descemet membrane from PDL, so you have an undulating membrane. And in type 3, you have a mixed type of DMD. This is an example of a large non-scrolled DMD, DLD, which is type 1, wherein Descemet membrane and Dua's layer are attached to each other. Another example of type 1 DMD, wherein Dua's layer and Descemet membrane both are attached. Another example of type 1 DMD. Another example of a type 1 wherein Dua's layer and Descemet membrane are attached, but they are detached from the stroma. An example of an undulating membrane, see, this is type 2 DMD. Another example of type 2 DMD wherein you get to see undulating membranes wherein only Descemet membrane is detached from the predesmetic layer, that is Dua's layer. And this is an example of a mixed type wherein you see a taut membrane, which is Dua's layer detachment here, and an undulating membrane, which is Descemet membrane detachment. So there can be various types of Descemet membrane detachment, and if it's extensive, then the outcome of these cases depends on the rapidity with which we diagnose and intervene. Most importantly, when we are doing a surgery and at that time there's a DMD, then we should have highest degree of suspicion. We should try to recognize it. Early recognition helps. If we recognize it, then suppose this is the main wound through which there's a DMD, then for viscoaspiration, you use a bimanual and don't use the main port. I would rather make an stab incision for bimanual somewhere here, because this is a little closer to the main wound. And as you can see, the lens has been implanted, but there's a small Descemet detachment, so bimanual irrigation aspiration probe is being used to remove the viscoelastic and inject air at the end of the procedure so that it attaches. the detached Descemet's membrane. As far as management is concerned, intracameral air helps in superior DMD, unscrolled DMD, and peripheral DMDs. But if it's an inferior DMD, there are scrolled edges, it's a long-standing DMD, then intracameral C3F8 should be used. And if it's a scrolled DMD, you should inject air or gas from the opposite side so that you unscroll the scrolled part. And at times when it's a long-standing DMD, you may have to give venting session, the stroma from outside, so that you drain the fluid that is collected in the supradesmatic space. Now, this is a case wherein there is a central DMD. This area is clear, so you can inject air from the clear area, and it suffices. Intraoperative OCT helps you to know the location and extent of DMD when you are planning to inject gas. Now, if when you examine the patient on the microscope, intraoperative OCT, you know which area is clearer. So the areas this area is clearer, and there's no DM detached here. So you make a paracentesis in that area, and from there you introduce the cannula and inject air, so that, as you can see here, intraoperatively you can understand that the Descemet has detached. These are some of the examples of how intraoperative OCT helps in managing Descemet's membrane detachment. Post-operatively, you give antibiotics, you give steroid. The most important thing is monitoring of intraocular pressure. So, in conclusion, DMD is fairly common condition which can be seen. There can be many DMDs which are small and self-resolving. But if there is a persistent corneal edema, you should have the highest degree of suspicion, and you should do a OCT and delineate the extent of DMD. And early intervention is beneficial, because if it persists like that, then there is endothelial failure. So early intervention, injection of air or gas in the anterior chamber, pushing the Descemet up so that it remains attached, and once it remains attached, it mostly stays there. Occasionally, venting incision for drainage of supradesmatic fluid is required in long-standing Descemet membrane detachment. Thank you very much for your patience.